know some of you already. I'm the National Nurse Lead for the National Strategic Clinical Network, and I'm also Deputy Head of Nursing for Anira and Bevan Health Board. So good afternoon, and thanks for taking up your time today. I'm going to give you an overview, as Joe said, regarding the Respiratory Network priorities, and update you on 3 projects that we're currently rolling out this financial year. Just waiting for my slideshow, bear with me. Okay, next slide, please. Okay, so the National Network was actually established in October 2023, and then Dr. Anthony Gibson joined us as clinical lead in April 2024. Since then, the team have actually expanded with several members of the clinical team joining earlier this year. The core team facilitate groups to links with the network with clinicians across Wales, and the aims of the network is to enhance and improve the quality of respiratory services that we provide, ensuring that they're safe, equitable, and they're sustainable, and that we achieve the outcomes and the priorities that we set out to support respiratory care across Wales. And this is guided by the quality statement, respiratory statement, that also sits within Health Board and Welsh Assembly Government. Okay, so can you all see the picture there of the core clinical team? So Anthony Gibson is our clinical lead. Hannah Hunt is our physiology lead.
Sorry, Natalie, can I just jump in there? The slides haven't moved for us. We're still on the first page.
Oh wait, bear with me a second.
There may be a little button on the bottom of your screen that says sync
there we
to
go.
presenter.
Yeah, there we go.
It's happening now.
Thanks.
Okay, so as I've said, the first picture, they're all familiar faces, I'm sure, but the first presenter is Anthony Gibson. He's the clinical lead for the network. Then we've got Hannah Hunt, who's the physiology lead for the network. Carwyn Bridges is a physio by background, and he's our allied health professional lead. Myself as a nurse lead, and Professor Julian Fortin is the paediatric lead. Next slide, please. We also have other key members of our core team, and without them, the network wouldn't function as well as it does. We've got Joanne Oliver, who's the network manager, Andrea Pace, who's the assistant manager, Georgie, who's our support manager, Christina, who's also our support manager, Nicholas, who's our senior project support officer, and Faseko, who's our program administrator. Next slide, please. Okay, so our work plan for 2025 and 2026 actually covers 4 sort of main priorities. Priority 1 being more around data. Number 2 is around clinical pathway. Number 3 is around service specification, and number 4 is around digital. So I'll just go into them in a little bit more detail. So priority 1 is looking at our audit data that we're able to access and trying to get it more unified across Wales. So we're currently looking at the development of a national respiratory dashboard. Also the National Respiratory Audit Programme that we're all familiar with, called NRAP. The visibility of pulmonary rehab waiting lists at the moment, because they're very central to the health boards, and we haven't got a sort of overview of Wales of current waiting times, and also respiratory diagnostics in relation to lung function testing and spirometry, focusing mainly on secondary care services at the moment. Then we've got priority 2, which has involved our clinical pathways. And as you can see, we've got a series of clinical pathways that the network are currently supporting. One I'm going to talk about a little bit further on through the presentation, which is the breathlessness pathway. Then we've got the optimal asthma pathway, which Katie Pink is leading on, the ILD pathway, COPD pathway, which Ramsey Sabat is leading on, and we've also got the bronchiectasis pathway. And then when we come to talk about service specification and other developments, there's lots of priorities around proactive winter planning in relation to virtual wards and COPD. And there's also service specification around COPD services and TB services. And the final sort of priority is around digital technology and the use of access to lung function within secondary care. Next slide, please. Okay, so as another key element of the network is the development of forums and several All Wales task and finish groups. So obviously you're all attending our sort of first virtual meeting, which is the National Nurse Forum, but we've also got forums in pulmonary rehab, sleep and respiratory, and forums for allied health professionals. And each of the clinical leads lead on these All Wales forums. And then we've also got the All Wales task and finish groups, which establish key pathway development across the 5 areas that I've already discussed. Next slide, please. So prioritising priorities, obviously we're competing against many demands and ministerial priorities at the moment. So the network is currently focusing on these 3 priorities while continuing with the work that I just discussed around the forums and the groups and the network plans. So the 3 priorities are the proactive winter planning, and that is around the COPD, which I'll talk about, integration of lung function testing, and the community breathlessness pathway redesign. Next slide, please. So proactive winter planning then, this aligns to the 6 goals for urgent care. In September this year, our network clinical lead, Anthony Gibson, met with the Cabinet Secretary to discuss winter planning. And as a result, a comprehensive guidance paper was written. This document outlines the necessary actions that health boards should take to reduce emergency presentations of our high-risk COPD cohort this winter. The guidance paper has already been sent out to our health board executives, and some of you on this call might already be involved in some of those local discussions that we're having at local level. Additionally, a joint letter was sent from the network and Welsh Government to the health boards. This letter addressed winter planning and the essential support needed for people with chronic respiratory conditions and symptoms of breathlessness. So these 6 key actions, which are identified within the slide, ensure effective supportive management. And like I said, they're adhering to the 6 goals for urgent primary care. So the first one is to identify those patients that are high risk. Number 2 is to ensure timely access to preventative interventions. Key is strengthen our community-based care pathways so that we can support patients safely and effectively at home. And this is important when it comes to coordination between all our areas, including primary, community, third sector and secondary care. Admission avoidance is key, and in some health boards we've now got a single point of access that we can utilise for a referral system. And also that it's really important that if those patients do need some expertise or specialist interventions, that they can be reviewed quite timely the same day in SDEC, which is the same day emergency care. Next slide, please. So the other key area that we've been working on is the integration of pulmonary lung function testing with the support within a Welsh clinical portal. So lung function testing digital access is now going to be available by this portal. And this is going to aim for standardisation across Wales to reduce variation, improve and enhance reporting, improve access to patient tests wherever you are, and that would then have an impact on coordination and patient outcomes. The current work is being supported by DHCW and Jaeger Medical, And it just ensures that the reports that are being developed are uploaded onto the portal so that everybody's got easy access to the data. Next slide, please. So as a result of this, there's been a manager appointed to support us with the development of the DHCW framework. There's been several work streams where physiologists across Wales have agreed to meet and develop a standardised report for lung function testing. And now we're currently at a stage where we're rolling this out across Wales, starting with Swansea Bay as our first site for the pilot, and then hopefully by March next year, 2026, it'll be rolled out across the other 7 health boards across Wales. Next slide, please. So the last project that we're looking at is a community breathlessness pathway, and looking how we can redesign something which is co-produced with a MDT approach, Once for Wales pathway, supporting adult patients. So that's adults over the age of 18 who present with unexplained chronic breathlessness in the community, integrating respiratory, cardiac and primary care services to deliver earlier, more holistic care. And as I said, this is a co-produced piece of work between the respiratory and the cardiovascular network, the strategic programme for primary care, and also the support of AstraZeneca and the pathway team to develop and assist us with the development pathways. Next slide, please. So to date then, we've had several collaborative meetings and national engagement. We've held several meetings across Wales on 3 sites, and 150 stakeholders from all 7 health boards have helped to shape the pathway and attended the workshops in July this year. As I've said, there was many multidisciplinary team members attending the collaboration work streams, including allied healthcare, our digital teams, industry, and obviously our partners across acute primary care and intermediate care from respiratory and cardiac. And what that team has been able to do is develop an integrated model of care for breathlessness. Those early engagements throughout those workshops have built really strong national engagement, and everybody's views in relation to the pathway has been incorporated into that. And as a result, a pathway report has been now prepared by AstraZeneca and is now being rolled out across Wales, which has been endorsed by the Performance and Improvement Directors Group. And as I've said, we're now starting the rollout of that. Next slide, please. So the next slide just illustrates some of the pathway work that has been developed by the team, and encloses some photos of the key sites, which was Swansea, North Wales and South East Wales, which was in Cardiff. And like I said, 150 people in total attended those workshop groups. Next slide, please. Okay, so the next stages now are implementation and innovation. So the pilot site readiness matrix has been developed, and this defines criteria for pilot site implementation. The pilot sites that have expressed interest are Aneurin and Bevan Health Board, Swansea Bay and Cardiff and the Vale. We've also got some innovative diagnostic technologies that we're hoping to use throughout the pathway as well. And these 2 pieces of diagnostic technology are called Tidal Sense and Nuvo Air. So Tidal Sense is an AI-enabled handheld device that analyses natural tidal breathing using CO2 measurement, and it complements, but it doesn't actually replace spirometry. And the other piece of technology is something called Nuvo Air, and this is a remote monitoring platform that connects patients and clinicians through home-based spirometry and symptom tracking. So really good for patients maybe who can't attend breathlessness services or clinics. Next slide. Okay, so the implementation then is living with breathlessness, and an all Wales universal self-management resource is currently in development. We've also been reviewing digital and data frameworks, so we've got a submittee group looking at the digital solutions that we're going to use throughout this pathway. We've got another group which are looking at proms and prems. This is a recently established group, and we've had 2 meetings so far and have come up out of 52 proms and prems. We've sort of narrowed it down now to just 3 or 4. So they will be implemented throughout the pathway at different stages. The evaluation of the pathway is actually being completed by a company called Tritech. But this is currently pending some funding. So phase 1 of the implementation is gathering some qualitative evaluation and early learning, which we're hoping to sort of report by February next year. And then phase 2 will start in March 2026 till the following year, which will be quantitative outcomes and health economic analysis. And like I said, those sites are currently meeting with the network now, reviewing the pathway. I think we have our first meeting on the 1st of December to look at how health boards implement the pathway local. What are the requirements for the pathway, because in some health boards we may have limited access to weight management, to psychological support. So all these interventions will come out and discussions as part of those networks. So next page. So the other piece of work that we've successfully implemented over the last year is in relation to Respiratory Matters webinars, and there's been a series of webinars held usually at a lunchtime since May, and these have covered a wide variety of different topics to promote learning, promote the network, and to raise awareness. So the topics covered so far have been we had a fantastic speaker talking about the respiratory digital dashboard. We've also talked about the green agenda and going green with inhalers across Wales. We had a discussion around NRAP and the reporting system, and also around paediatric asthma. And just a few weeks ago, we had Katie Pink talking to us about the new adult and asthma guideline. We've also developed the network website, where it contains all the information from the webinars that we've completed over the last year. It also contains newsletters, and as a nursing forum, we're also looking at establishing an intranet page for nursing educational material. So we're currently having conversations about what educational materials are used across health boards and whether we can pull something together for a Once for Wales. We've then got our newsletter, which has been sent out to everybody. You should have all had a copy of this, with Q1 and 2 for 2025 already being published. And within that newsletter, it includes good news stories, updates from the networks with the priorities and the progress made, any staff news from the network team, as well as the groups and forums and the priorities that are currently being undertaken. Next slide, please. So this is the QR code for the network website, which will give you all the information that I've just discussed. You can also sign up for the webinars and newsletter by using that link. And we've also included the network email. So if you've got any communication or anything you want to raise, then you can do it quite successfully through that link. Next slide. So just want to say a big thank you all for attending the session today. Anthony was going to do that session for us, but unfortunately he couldn't make it today, but I'm sure he'll join us at one of our future network meetings. And I'll pass you back over to Joe.
Thanks, Nat. Clearly a lot of great work going on, and certainly from my perspective, having been around for far too long, and seeing various changes in strategic changes. There's certainly, it does feel as if there's a difference. It feels like the people on the ground are being engaged with properly, and that there's an implementation plan, because often we've had documents created, given with nothing behind it. So I think that there's a lot of good work going on, a lot more to come, I'm sure. Has anybody got any questions for Natalie? Only thing I'd say is that you mentioned a couple of great things. If people want to have the link to the dashboard, where do they find that? And also the report that came out on the breathlessness pathway. I'm assuming that's probably on the website, and is the dashboard link on the website as well?
Joe, what we'll do is we're just updating the chat bar now with all the links,
Smash
so
it.
everybody's got easy access to it.
Great. Anybody got anything else to say? Smash it. The only other thing that came into my mind was, for example, the implementation of the digitalized lung function results. I'm sure, well, you could correct me, it must have made a difference having a physiology forum that you could go to look at an all Wales solution and implementation as well. It must make it easier when you have got that sort of body. So, so hopefully as a nursing forum, we'll be able to play similar parts in key nursing things as they crop up. So it is important, this forum. Thank you very much, Natalie. She'll be back later. So we're going to move on. We're very fortunate to have Joseph Carter, who heads up the Devolved Nations? I want to say Celtic Nations for Asthma Lung UK, but I'm sure he'll correct me. Yeah. Devolved Nations, okay, Devolved Nations. And another sort of hot topic on the back of what Natalie's just been talking about is he's going to give us an update on keeping people with lung conditions well at winter. And I think definitely this morning we were in the middle of winter when I had to scrape my car for the second morning running. So over to Joseph. Thank you very much.
Thank you very much, Joe. And yes, I had to briefly scrape my car as well, which was not expected. So thank you for that. I hope I am sharing my slides. Hopefully, Georgia, if else can indicate that is the case. Can they be seen?
Yeah, we can see them.
Good, excellent. Okay, well that's good. That's always a good start. Okay, so I'm going to talk about winter, specifically our winter health guide that we developed as a charity last year. We're rolling out again, and I suppose I come to ask your help to disseminate that amongst your patients and amongst other healthcare professionals that you might be working with in your teams or your practice. So there's a lot of stats and images I'm going to share with you, some which will fly by quite quickly, and I'm always conscious in an audience like this of telling you things you already know, and I do appreciate there's probably a spread of those working in primary care versus hospital wards versus secondary care in the community. So some of this will be very much known to you. Others you may well think it, feel it, and suspect that it is the case, but not necessarily have seen the raw data before. So yeah, but hopefully it'll all make sense. So just to begin, and I often put this in my slides and I'm presenting it to people, just to remind us all that lung conditions are the third biggest killer, killing thousands of people in Wales every year. And one person dies roughly every 2 hours fighting for breath. So by the time we finish this hour-and-a-half session, there's a possibility that someone in Wales would have already died of a lung condition in some circumstance. So which is a pretty terrifying, chilling thought, and more of those people will be dying during the winter. So the aim of this project was to help reduce winter-related hospitalizations by supporting people with chronic respiratory conditions. We wanted to focus on education, self-management, and a system-level collaboration, which is very, very marketing speak, but that was the official mission. And we're doing this because we know that winter is a perfect storm for respiratory illness, that there is a time when we get these huge jump in hospital admissions, which I'll come on to in a second. And UK-wide, we know that hospital admissions for lung conditions have doubled in the last 20 years. And this is something we've seen here in Wales as well. But the admissions do differ. COPD, UK-wide stat here, 1.2 million people diagnosed. Exacerbation is obviously increasing quite a lot in the winter. COPD on its own is the second most common cause of emergency admissions, which is incredible when you think of that. Just COPD, not lung conditions as a whole. Asthma, it's a UK figure again. 5.4 million people have asthma across the UK. But two out of three of those hospital admissions are preventable. And RSV, which I'm not really going to go into much today, but it is covered in the winter health guide, is of a growing interest and concern for us. And winter before last, 13,000 plus adults were admitted during on top of those with COPD and asthma. So it's a challenging picture. And to put it in the wider all year round context, when we look and ask people about their experience of asthma care as part of our life and lung conditions surveys, people tell us that actually most of them are not getting the full aspects of basic care. So only 30% of people in Wales were telling us that they were receiving the three main components of good asthma care, the worst out of the UK. And we've seen a slight increase on last year's horrendous drop to 21%, but still, it's 2/3 of people are not getting that basic care. And by basic care, most of you know, we are talking about having an annual review, having your inhaler technique checked, having access to a written action plan. And you see generally Wales is at the bottom of these, with the exception of inhaler technique. COPD is a fairly similar picture in the sense that it's not very positive. So we've been doing this for the last 5 years now. We've seen the rates of the support for people living with COPD drop from 17.4% in 2021 to 5.6% this year. Pretty stark figures. So over 94% of people not getting the 5 aspects of COPD. So that's the context that we're currently facing year round. Now, next few slides are some stats that we came out of not last winter, because those haven't quite been released yet, but the winter before, just to give a context of the challenge that we are facing. So again, these are Wales-wide figures, not UK-wide here, but there were over 18,000 emergency admissions during the winter for respiratory condition, about 149 every day on average. And looking at all respiratory admissions rather than specific conditions, we found they were 40% higher during the winter than they were during the summer. In fact, 2 out of 5 of respiratory admissions occurred during the winter. If we look at children specifically, and this is children in a whole variety of different lung conditions, over 6,000 children were admitted to hospital during the winter months, 2.5 times higher, in fact, in the winter than in the summer. And the deprivation figures here are incredibly stark. So the most deprived 10% of Wales are 70% more likely to have an emergency respiratory admission compared to the least deprived 10%. Which, when you think of the issues around poverty, around larger smoking prevalences, where people live, damp, mouldy housing potentially, these things make sense, but it doesn't make them any less distressing. So over 6,000 childhood respiratory admissions over the winter. So asthma as a whole is much smaller numbers here. So 900 asthma admissions in total during the winter. So this was quite an increase, 60% increase, 6% higher, I should say, in the winter than the summer. Deprivation obviously being a factor here as well, but quite a significant peak there, but much smaller numbers. And again, if we're looking at childhood asthma, and we're looking at thankfully relatively small numbers here. 300 children were admitted at hospital during the winter, but again, that's 300 children too many. And you see deprivation is a major factor here. 80% more likely to have an emergency admission in the most deprived parts of Wales than in the most affluent. And as you can see from the top point there, that it was over twice as likely to be admitted in the winter than in the summer. So very challenging for those children, and of course their families supporting them. But we're going to COPD, we're looking at much bigger numbers. So over 5,000 COPD emergency admissions during the winter months, 30% higher in the winter than the summer. So we also have challenges all year round, but we get that peak in the winter. With deprivation, again, you're 3 times more likely to have an emergency COPD admission compared to the least deprived. And that's an interesting one, because when you think that numerically as well, that COPD is a condition that does affect more people who are from the more deprived parts of Wales than the most affluent. Again, this adds to the mass of people that we are talking about here. So, and as I've already said, but just to sum up across a whole variety of different conditions here, you can see the deprivation issue is there across all respiratory conditions. It just varies. So 70% more respiratory across the board, 80% more asthma emissions, 3.5 times the number of COPD emissions. So deprivation is the key thread running through a lot of this. And in its totality, this was a figure which particularly surprised me, that one in every 4 winter admissions is for a child under 10. So children under 10 make up almost 1 in 3 of all respiratory winter admissions. Those over 60, in comparison, make up 2 in 5 of those winter admissions. And I said then you've got the asthma stats there. So 1 in 5 asthma winter admissions is a child under 10. 1 in 4 asthma winter admissions is an adult over 60. And as you might expect, those over 60 represent the 5 out of 6 of those COPD admissions, which again, you might make sense in terms of the age profile of people living with the condition. So a lot of numbers there, a lot of stats, and I'm sure you see it with your own eyes, you feel it day in, day out with your own people you're supporting, but still very stark. And I suppose in conclusion of all those figures, the reality is that when it comes to winter and winter pressures, as Natalie mentioned before with Dr. Gibson's conversations with Welsh Government, we are the winter pressure. It's not people slipping and breaking hips, it's people living with respiratory conditions, and vast majority of these emissions can be avoided. So just to move on, and some of you have seen the stats before, but others you might not have done, but just to kind of recap in terms of the cost of respiratory conditions here in Wales. And so we did some work with PwC 2 years ago now. We published this data, but so inflation's obviously would have raised some of these numbers, but we still use them. So asthma costs the NHS in Wales £84 million. People think of asthma being a relatively cheap condition because inhalers are fairly cheap. Yeah, but there are an awful lot of people living with asthma, so that's why the cost is so high. But if you look at the total cost of the Welsh economy due to people not working, due to lost quality of life costs, it's £335 million because the population is so relatively young. In COPD, the NHS costs are much higher, £211 million, despite the fact that the population with COPD is much smaller. The needs are greater. But because of the age profile, there's obviously less of a productivity cost there, but still leading to £427 million cost to Wales. So in total, these 2 big conditions on their own cost £772 million. So back to our campaign. So we launched last year our winter campaign with the aim of trying to keep people well and ultimately save lives. We focus it not just on flu and respiratory viruses, but also looking about air pollution, damp and mold, vaccinations, and cold weather. We had a variety of what we call paid and owned social media, where we paid for advertising in different places. Here's an illustration of some of our literature. There's some of our with a couple of billboard sites. We paid for a small number of bus stop related sites as well, and we had a variety of media coverage, some social, some in newspapers, some we had to pay for advertising space. And we also did a partnership with Toby Ansteds at Heart that I was particularly excited by from my childhood memories of Toby Ansteds. But great guy and very passionate about sharing his story about asthma as well. And here's some more examples of the news coverage we got. We also did some specific tie-ups in England with some of their ICBs, where the ICB collectively got involved with the campaign. Whilst generally across the UK, it was individual healthcare professionals who got behind it. So what was it? What did it look like? So this is a sample of our online winter health guide. So essentially, it was a regular set of emails being pinged out to people who'd signed up to it, being led by our Dr. Andy Whittemore. It was personalised based on people's triggers and their conditions. So we asked a variety of questions first to try to find out what circumstances people were facing. And we tried to keep it warm and positive in its tone. Slides seem to have frozen for a second. There we go. There we go. Oh, gone too far forward then. So the campaign objective was to ultimately inform and educate people with lung conditions about danger of winter to them, but ultimately wants to try to avoid A&E visits. So when we asked people about how they found what their feedback was, 96% of people felt it was either somewhat or very useful. 71% of people told us they were better able to manage the lung condition throughout the winter, and 41% of people felt that the information had stopped them going to A&E, which is a crucial fact here. What that meant, so in terms of the people who filled in the survey, that was only 650 people told us that they would have avoided going to A&E because of our winter health guide. Even with that small number, the estimated cost saving would be about £1.6 million. But if we took a leap of faith and extrapolated the percentages across everyone who actually who took part in the winter health guide, and that is quite a leap of faith, that could have potentially kept 35,000 people out of A&E with savings about £88 million. So there's some big numbers here that could have been achieved due to last year's winter health guide, and we're keen to replicate that this year going forward. We had targets around reach as well, so we reached over 15 million people, including 3 million actually living with lung condition in themselves. There's some stats here around page views and engagement rates and that sort of thing. But as I said, 27,500 people signed up to the winter health journey. And so this is marketing speak here, I apologize, but this is ultimately how we did it. So we're focusing about earned media, owned media, paid media, as it were. So this is how we engage people, and it's a marketing funnel ultimately that my marketing colleagues understand and I struggle with. But that's an honest reflection there. And to give you a snapshot of, I suppose, where people were. So as you can see, we had coverage generally across the UK. There's a large kind of blank bit there in parts of Powys I see, but there's a lot of rurality there and not many people living in that part of Wales. So that's perfectly understandable. But this dashboard, when it was published at that point, it was 33,000 people. So and these and we can also look about the areas of deprivation where people live as well, and look at the difference breakdown of conditions at point 2 as well. So that's how the campaign went last year. Anyway, looking forward this year. So we're running the campaign again. We'll try and make it bigger and better and try to get more people getting the information to keep themselves safe. So here's some of the artwork we put together, and actually these are mocked up locations. These aren't the locations have not actually gone. They haven't gone into the locations yet in these ones. So we changed the messaging slightly. It's focusing on this idea of we're with you all winter. So that's the kind of messaging we're going with here. So here's some of it. So there's old and young. We've got we do stick of our quite stark black and white imagery, trying to really resonate just how serious lung conditions are during the winter. Here's a snapshot of some of our so this is our social media carousel, as they call it, which is currently going out at the moment. Here's some of our sponsored our sponsored social media marketing as well. So trying to funnel people through to the Winter Health Guide, and obviously we've been beaming it out to all of our hundreds of thousands of supporters as well. As I said, last year we managed to potentially saved that sort of level of money across the NHS. Definitely the 1.6 million, potentially the 88 million pounds. So yeah, we want to do better than that and get more people, more than 35,000 people using this. So how do you do it? So those of you who've got your phones in front of you, you can scan the QR code there and download the Winter Health Guide today. The actual URL, the website address is at the bottom as well. It also works, as I've found myself when I've been there trying to tell people about this. If you just go asthma and lung UK, sorry, asthmaandlung.org.uk/winter, it takes you there as well. So, but that is the actual URL link. So yeah, please scan the QR code. Please use it. We will be disseminating this information to people to try to encourage as many people through the network to get behind the campaign. PHW have said they'll support us as well. So we want to ultimately try and keep people safe and well and out of hospital. Thank you very much.
Thank you, Joseph. Any questions? Anybody? Don't be shy. Now's your chance. I think, well, that's a link. I think what's still strikes me after listening to some of those figures is how poorly that we are doing, really, and the decline that there's been since COVID. You know, it's quite sad, really, when you look at it. Think of us as health professionals, how we are, you know, failing, really, whether it's us or the systems we're working in. And I think what's a shame is it's the simple things that make a difference. You know, when you look at COPD, it's the smoking cessation, the vaccinations, medication, all those things will make a difference to patients' lives and things like hospital admissions that we're so under pressure for. And similarly in asthma, you know, basic things like inhaler technique, medication, action plans do make a difference. And I think, you know, we need to do a lot better. The NRAP data is equally as poor, I think. Anybody have any questions? Go on.
Joe, just respond to that. I think ultimately you're all working incredibly hard to try to support people. You're obviously limited by what resources are available to you, and particularly in primary care. And there's only those of you working in the community. There's limits to what you can do when primary care is overstretched. And there are obviously lots of societal factors that are our policy issues ultimately, and you as a healthcare professional can't stop the fact that someone's living in a damp and mouldy home. You can't stop the fact that you can try to stop the fact that someone's smoking, but that's there's the limits to your abilities to do that, and the fact that I think anyone who signed up to this webinar who is on the books, as it were, for our Respiratory Nurses Forum, clearly invested in trying to improve respiratory health, and you're doing all the best stuff. But I was struck when Joe, you and I were at the Health Hour in-person studies in Pembrokeshire, some of the stats around smoking cessations in hospital, and actually you've got perfectly qualified non-respiratory people working on wards who just haven't necessarily got the headspace or the time to think about smoking cessation. Whilst you all know it, that's your bread and butter. But for those who are non-respiratory people and just trying to get through a crazy shift and try to manage the flow of patients, you're not having the time to really think, I'll get the smoking cessation person up to come and help, and thinking that long-term prevention issue, and that's hard. But as I said, don't give these figures to try to depress, although it is depressing. But these are things we can avoid, and hopefully by the efforts of all health boards and the fact that we're told, Anthony Gibson's been told that respiratory will be a priority for the NHS, that we'll see some improvements there, and you and I, Joe, you would know examples from before the pandemic, which thankfully don't happen that much nowadays, when you see pulmonary rehab services decommissioned during the winter because of firefighting, which thankfully that seems to happen a lot less than it used to. So thank you.
Yeah. Well, thank you for supporting us and all the support that you give. I know across Wales to all different organisations and bodies, and also flying the flag and standing up there for patients and putting pressure on our politicians and everybody else who needs to be reminded of where we're at with respiratory. And of course, there's interesting times ahead with the election coming up. I'm sure there'll be some changes, hopefully some positive, which will be good for us all. So thank you once again, and we're going to move on to our next speaker, who is Chris Davis, who's hopefully going to tell us maybe about one or two solutions to some of the issues that we've been hearing about. Certainly, I know from personal experience and the colleagues that I work with, the important work that ICST has done, not only from an educational perspective, but also with things like the apps. And we're being fortunate that ICST is going to continue. And as part of that continuation, I think the deal is that us as health professionals use the platform more and encourage patients to use things like the app. So I'm going to hand over to Chris, and he can enlighten us all on where we're at and what we need to be doing, I'm sure.
Thank you, Joe. And can you hear me? Is that?
Yeah.
Yeah, that's great. And Joseph as well, who actually sets that scene very nicely. So I'm just going to share with you also some slides. Can you see that?
Yep.
Yeah, great. Okay, so yeah, good afternoon, everyone. And thank you for inviting me today to share some updates and data on the All Wales respiratory apps. I'm Chris Davis. Thank you for that introduction. Many of you will know ICST, and specifically through the All Wales platform and the Health Hub apps. But I will go over a few bits and pieces for those who may be new to that. And what I'm going to talk about in the next 15-20 minutes is going to be just about what is the respiratory toolkit itself, and what is the data telling us from that, because we do gather a lot of data, which is all part of the feedback loop. And with that, how can we get more patients engaged with that too? And we'll go through some of those things that will be hopefully possible for you to help. Well, look, there are two main components of the respiratory toolkit, and they're very simply split into patient-facing through the apps and the All Wales platform, which has got the guidelines, and we'll talk, and other educational and quality improvement programs, and I'll talk about those a little bit later. But we'll start off with the apps and the patient-facing things. Now, there are three apps. There's an asthma app for adults, asthma hub for parents, for parents with children with asthma, and the COPD app, and they're all available on Google Play and the App Store, and there are also web versions available as well. I think the main thing here that is really important to understand, and I think the whole focus around the apps is about creating expert patients, and this is the real thing. This is about how do we support patients in order to stay well. So there's a range of education, information, people to be able to put and hold their personal data on their condition, and advice. And the question really is, why is that so important with all of this? And the evidence over many years, decades in fact, shows that patients who are expert in managing their condition, regardless of what that is, any chronic condition, have one, better wellness, and two, they're more confident in managing their conditions, and then as a result of that, they have better consultations and interactions with the health system. They have more agency, and those interactions are more efficient, and the need for having interactions with the health system goes down. The health service utilization is reduced, and so there's a lot to gain. And Joseph shows all the data that was coming out of Asthma Lung UK, and there is obviously a very large burden. So there's a lot to gain here. And this is why within the apps, what we've created, and this comes back to the data, which I'm going to show you after we've been through some of the things. And this is a new thing around the apps, is that we've created a program for patients to become expert patients, and it's run over a 4-month period. And it won't be of any surprise that it's all driven by the things that we know have high value based around the NICE guidelines, the things that are priorities within a clinical environment, the NRAP reports, etc. So the things that make people well, keep people well, are built into that. So whether that's smoking cessation, flu vaccinations, having care plans, etc., they're all built into that. And over a period of time, this knowledge and behavior model where patients engage and integrate with their health condition, and they're supported to improve a lot of the things that they can do themselves, they end up over 4 months becoming expert patients. And that's really important, because it's not just about knowing what to do, but it's also doing the things regularly that that enable people to stay well. Here we can see there are other things that can be useful, that people can hold their hospital, GP visits, medication, again, education and support. And that just is very much part of that overall management. Now, the Asthma Checker has been around since the app started several years ago, and we get a lot of data from this. And the checkers are, if you like, a questionnaire almost that patients will fill in every month, or we encourage them to fill in every month. And these were put together with national leads. A lot of work went into what would go into this. And there are various components really to understand how people are and how well they are at any one point in time, but also what their behaviors are. So are they getting their medication? How are they taking it? Have they been to A&E or to a hospital outpatient, or needing some rescue medication? And then at the bottom, you can see the RCP3 questions, which is very much built around their wellness status during that month. And patients are then able to catalogue and look at this over a period of time and see how well they're doing compared to the previous year or the previous month, and of course take that to their healthcare professional. And this is the one for COPD, which is slightly different because there are the RTP3 questions are not relevant, but it's the same ethos of trying to get information as to what is the health status of patients. The healthcare professional toolkits you'll probably be familiar with. They consist of guidelines, which many of you will see within GP practices or various hospital departments. And then it's also supported with education and quality improvement programs. And the quality improvement programs are the official NRAP programs. And so it's endorsed and supported, and we link in very much with the national NRAP team. So these things combined, really are there to support primary and secondary care teams that are working on the front line, and to make it easier to deliver care, for patients to take more responsibility and ownership of their care. And within all of that, outcomes improve. And as Joseph alluded to, if patients are not getting sick, not going into hospital, there are huge amounts of efficiencies and cost savings. So we're totally aligned in that respect. So if you look at the data that comes out of this, because of course, when you have a digital system, a good digital system is a system not only that reaches out, but also gets feedback, because there's no point in not being able to measure what we do. And so we look at a lot of the data that patients put into this system. So this is not just survey data, although we do that, but it is also data that comes from patients utilising this throughout the year. And I'm going to go through this is not all the data that we have, but it's a selection to give you a flavour of things. So this is the monthly checker data, looking at patients that the lower line here, the dark blue line, are new users that come onto the system. And when people register and they come onto the app and put in their data, they will get their monthly checker score. And over time, when they continue to do that, you can see how that might change. So, of course, if they have an exacerbation, it might go down. But if they get better control, that will go up. And what we find is that within even less than 4 months, you can see that the orange line there's clear daylight in the checker scores, but actually even more so after 4 months. So 4 months is a real period of time where patients have had the chance to embed behaviour and also to get the benefits of those behaviours over that period of time. If we look specifically at the RCP3 questions, you can again see this improvement, 33% improvement, within this period of 4 months. And interestingly enough, what we have found is that the patients who have got the greatest amount to gain that we have found is in areas of deprivation and young. And in fact, during an evaluation last year, it was looked at to see where the uptake of these apps were being used. And over 21 variants, if you take 3 apps in 7 health boards, so 21 variants, within 20 of those variants, there was no difference in uptake within areas of social deprivation. So I think that the point that Joseph was saying is really important. And if we take that data, plus the data here of showing that hard to reach groups in areas of deprivation and young people that our results are showing that they are achieving the greatest improvements, but also this is a mechanism to reach them, is really positive. This is about inhaler use. More data showing that the lack of need to use a reliever inhaler, again over that period of time, the 4-month period, it really changes. 35% and 20% of not even using it at all. And this is some pediatric data. And what you see here is that not only is the graph showing that there are reduced GP visits, now reduced A&E visits, reduced courses of prednisolone, and also fewer hospital admissions right the way. So all of the data is going in the right direction. The numbers here actually show the absolute percentage reduction, but in terms of proportion, the GP visits, the proportion drop is not 12.9%, but 35%. For the prednisolone use, it's a reduction in 47% in prednisolone use. And A&E visits, that would equate to 54% and 52% in fewer hospital admissions. So real data coming from people putting in their information into their system and just showing the fact that they are not using the health service so often because they're staying well or less unwell. And if we take some paired data, this is in adults, looking at 2 different winters. So we take winter, this was done for 2022-23 winter to the 23-24. And you can see that this paired data, so it's looking at the same people between those 2 winters. And of course, there are confounding variables and factors that would come into all of this. So we have to take all of these things into account. But yet again, we see a massive reduction in utilization of services through improved wellness. This is not to do with wellness, but it is still data that has come out. And this is published data, but a different priority, and that's to do with global warming inhalers and switching from MDI to DPI inhalers. And this is a comparison graph that is between England and Wales. And what you can see is the difference between patients who are switching to dry powder inhalers from MDIs. And in fact, in England, if you look at where this data was first collected, right the way back in, I think it's 2017 back there, it's actually not improved at all. And when this was looked at and written up recently, out of the 4 nations, England represented this, was the same as Northern Ireland and Scotland, where there was no difference, and everybody utilised the same infrastructure and way of getting through incentives of financial payments and mandate to improve uptake of DPIs. In Wales, it's been a very, very different story, very much driven by this behaviour change model, getting out through you as healthcare professionals and patients, certainly patients who are utilising the apps. The numbers are very, very high of dry powder inhaler usage. And it shows that this behaviour change thing has, where it's failed in other countries, has been very successful. So another example and a good success story. So how do we get more patients utilising the apps and getting the benefits of this? Just some quick numbers. There are tens of thousands of patients, mainly with asthma, admittedly, and healthcare professionals, nearly 17,000 healthcare professionals of lots of different specialists, using the platform. And how is it that we can, improve that? What we show with our uptake is you will see this sort of lower level baseline that happens here, where there are this all relates to the number of downloads that happen, and the lower level that happens, this baseline throughout, is really a marker of healthcare professionals introducing patients, because we know most of patients that adopt these apps come through their healthcare professionals. It's about 80%. 2/3 of that through primary care, and 1/3 of that through secondary care. Where we see the largest spikes are where GP practices have reached out to their cohorts and emailed or messaged out to them, inviting them to download the app and get the benefits. And there's a whole load of stuff on the All Wales platform with message content and things for practitioners to be able to do that. And certainly we strongly encourage that, because it does make a huge difference. And there's lots of campaigns that go along with that, and we support that with patient facing events that some of you might have been involved with, and also on online events and campaigns that go on throughout the year, whether it be from supporting people to do the right things like getting their vaccines, or indeed to download and utilize the app. So that's a bit of a whirlwind, but I hope that that's given some insight as to where things sit with the toolkit, specifically the apps.
That's great. Thank you very much, Chris. Any questions for Chris? Don't be shy. Yeah, Tanya has got a question.
I just want to ask Chris, in relation to the apps that the patients use, is there a way that we could actually see as clinicians that information coming through? So I'm working with the PROMS and PREMS team to look at some of the questions that get sent out to patients, and I'm wary of duplicating a lot of the questions that these patients may be getting through the app. As well as us asking as clinicians. And I think if there is a way that we could integrate that information onto our services when they come in for their reviews, we could reinforce the importance of the app and the fact that we're actually checking their trajectories and how their symptoms are going, etc. So I don't know if that's something that ICST and the other people could actually get together and look at in future. If we could link the services, we might actually find that patients don't get overwhelmed with all the technology, and we all sing from the same hymn sheet, particularly when you say that healthcare professionals like GPs actually promote it better and those patients have a better uptake.
Yeah, no, that's a really good question, and that, I think that's absolutely vital. So there's a few things there. So first of all, the answer to that is yes. Do we have the ability to do that? The answer is yes. So from our perspective, linking in with that is fine. It's really more around the other sides of the governance and being able to do that. So there's a couple of things here. First of all, we have a dashboard for healthcare professionals, which by consent of patients to see that data, healthcare professionals are able to look at that data and see the sorts of stuff I showed you through the checker, etc. There is a button on the app which also then can be seen on the dashboard. So it can be done in two ways, either with a patient sitting there. So there's a few things. One is that for an annual review, when a patient comes in for an annual review, they're able to click and show a resume, so that all of the data that a GP or practice nurse or whoever's doing the annual review would need, that data would be available. So you don't have to, ask the patient and they have to recall everything. It's all it all comes out. So it makes the consultation more efficient and quicker, and we would say more accurate, because the data that goes in there is at that point, rather than thinking about, was I admitted, twice or three times to hospital or whatever. And that's been done really to make it easier for that consultation, to give more time into sort of planning how one can better support and manage the patient. All of that data can be integrated. So yes, perhaps we talk afterwards at how we can maybe expedite that, but there's absolutely no issue with that whatsoever.
Thank you.
Any more questions? You're going to pop the hand up. I thought it was quite interesting when you mentioned about the uptake and the poorer uptake in the areas of social deprivation. I think that's what you said, didn't you?
Yeah.
And these are the areas, obviously, that are having the poorer outcomes in terms of probably quality of life, healthcare utilisation. And I guess the big question is, how do we reach those areas? And when you mentioned about the GPs having a spike in uptake when GPs did mail shots or whatever, were they in the more affluent areas or the areas of social deprivation, or was it mixed?
Well, it's both, because the uptake's no different. So we will have spikes in areas of the most affluent parts of Wales and the most deprived, and overall there is no difference. And that's really quite remarkable, because most of the time in digital health, in fact in healthcare, areas of low social deprivation index don't engage with services, full stop. And this comes back to really about patients having agency. Patients who have the tools and the ability to support themselves appropriately, obviously not to take the role of healthcare professionals, but we know as healthcare professionals, because we have knowledge and understanding, that actually we're able to do a lot more for ourselves, and often in fact support family and friends who don't have that. Patients who do have those tools do better. And my personal belief is that there are lots of patients in areas of social deprivation who do find it daunting, to possibly more daunting, to go and engage with the health service as well with other services. There's not always the confidence, that they don't have the same level of maybe education, articulation, etc. And having something that they're able to then utilize can be very powerful for them, because they don't have to have access to traditional healthcare services. This is something they can do for themselves. So you're able to reach places where that population are not necessarily engaging directly, and I think that's a really, really big part of this. So there's a lot of work in terms of coordination, but we can't do this on our own. We can only do this with the support of practices wherever they are and secondary care, whether it be in deprived areas or otherwise. But it's a really great success story.
Maybe it's something that we need to try and look at further through the nurses forum. Obviously, we've got lots of people on our mailing list, and we can reach out to them and maybe look at strategies that we can work together and try and increase uptake.
Well, there's one simple project that takes about half an hour. It's a QI project with the NRAP, and on the platform, the healthcare professional platform, there's all of the data. So even what would go into an app with the links and into a message that would so that people, healthcare professionals or practice managers, if they text message out or email out to their patient list, it's got all of the stuff that they need in order to do that. And where practices have done that, you see the large spike. It's not the only thing, but because of course in consultations, and the more that it's used in consultations, the more that feedback happens. But we do see that and report that back to the practice that has done that, and tell them of the success of how many patients that came onto the system.
Natalie.
Thank you so much, Chris, for your presentation. Just to highlight, I don't know whether you're aware at the moment, but there's a couple of us on the call today who's currently involved in what's called the COPE template. So the COPE template is a COPD template, which is currently in pilot phase that we're using it across a few GP practices, 21 practices actually across Wales, and this supports COPD consultations delivered by our general practice nurses, and within that it highlights and red flags specific areas, exacerbations, hospital admissions. But what we've also done, Chris, is we've embedded the app within the template. So the GPN or the GP, whoever's using that template within clinical practice, can automatically bring up the app for the patient who sat in front of them. So there are some tweaks that we will need to do in the new year, and we're hoping then that once those tweaks have been done and we've had the feedback from the audit, that we'll be able to send it out across Wales. And then the question will be around the development of an asthma template, ensuring again that the app is incorporated within that. So I think that will support uptake from a general practice primary care point of view for the future.
That's brilliant. And I mean, I think coordination and working together is so important, because if there's anything that can be built into the app, we've made iterations over the years. That the expert patient was done from feedback. Tanya was just talking about prems and proms. If there's a way that we can capture data that can help, or where that would be. I mean, I think that the conversation, because there's 100% of GP practices in Wales have patients using the app, but that might be 2 in some practices, and it might be 200 in others. And I think the job here now really is that we know that there's benefit there. And why would there not be? Because this is evidence-based medicine. And when you put that in the hands of patients who can use that when they're in their own homes, of course, it's going to help them as a population. The question is, how can we get the spread is very good and the adoption across practice, but how can we get those numbers right the way across Wales up? And if we can take those numbers from 20,000 to 50, 60, 70, 100,000, then Joseph's going to have different figures to be presenting. And I think that it's about working together to do that. But I look forward to hearing Joseph present in 2 or 3 years' time, and those those figures looking markedly different in Wales, and Wales also leading the way, because there isn't another country anywhere that has got this level of success. It just doesn't exist. In pockets or pilot studies, you can reproduce anything, but on a national basis, there's nothing that comes close to it. And so it's so much of the groundwork has been done. I think a push with the things that Natalie and Tanya are talking about. I think it's there for the taking, and a great success story for the country.
I think we're very fortunate in Wales that we are trying to work together. And we've got some great outcomes, and
Absolutely.
certainly you have people in England, Scotland are quite envious of some of the things that we're doing. So it's all definitely positive. So thank you very much, Chris. That was excellent. I'm definitely keep in touch, and maybe in 2 years' time we'll have you and Joseph back on, showing us all those figures that have improved. And in that time, we need to all work hard to improve app usage and those outcomes. So thank you. We need to move on, or I'll get told off. The next item was about future